This presentation will be covering erectile dysfunction. I'm Bethany Von Hoff, and I'll be your presenter today. Similar to most of the other presentations so far, we will talk about the prevalence, common causes and risk factors, as well as treatments and related treatment information for erectile dysfunction. Erectile dysfunction, which I may be referring to as ED throughout this presentation, does not have as clear of a definition as other diseases or diagnoses. A common definition is the inability to develop and/or maintain an erection for satisfactory intercourse or activity in the absence of an ejaculatory disorder, such as premature ejaculation. You can see how this definition becomes a gray area because how do you define satisfactory intercourse and who sets the definition? Is it from the individual experiencing erectile dysfunction, the partner? Does it become a standardized clinical decision? Also, there are varying opinions on how long or how often it should happen for it to be fully diagnosed or classified as erectile dysfunction. In general, people lean towards this inability for greater than 3 months. Because of this somewhat unclear definition, prevalence is hard to assess. Additionally, patients may not seek medical treatment if they are embarrassed or feel uncomfortable discussing it with the doctor, and the definition is very subjective, so it's difficult to assess the true prevalence. However, based on some of the information that we do have, it's estimated that about 30 million men in the United States experience chronic ED. The prevalence increases with age. One study reported that at age 40, approximately 40% of men have at least been affected by ED at some point, and that number goes up to 70% at age 70. However, complete erectile dysfunction is estimated at a prevalence of 5 to 15%, going from age 40 to age 70, but transient ED can affect as many as 50% of men between ages 40 and 70. Before we talk more about erectile dysfunction, it's helpful to understand what happens normally or typically in an erection to understand where there is dysfunction. So in an erection, there are usually 4 main body systems involved. The vascular system, which provides the blood flow, the nervous system, which is responsible for signaling receptors and neurotransmitters doing electrical signaling, the hormone system, which is primarily through testosterone contributing to sex drive, and then the psychological system, which includes things such as desire and sexual stimulation, which creates a psychological component to it. So in the normal process, and most of the time, the penis is in the flaccid state, and blood flow is going in and out of the penis at a balanced rate, so as much as coming in as is going out. In the erectile phase, though, there's an increase of blood flow, and that fills the tissue, which then puts pressure on the blood vessels, which decreases the outward flow of blood. So then there's more blood coming in, filling the vessels, and then this is what leads to the increased size and rigidity of the penis. Now that we have a better idea of the normal physiology, let's look at some of the common causes and risk factors and consider how this might affect the normal pathophysiology. It's very important to do a thorough assessment of a patient, including medication review, physical exam, medical history, and lab tests, as usually erectile dysfunction is not occurring out of nowhere. It usually can be linked to one of the risk factors or common causes. So if you look at some of the concurrent medical conditions that can be risk factors, such as smoking or high cholesterol or hypertension, if you think about it, all of these can be associated with the decrease in blood flow or reduced blood flow. So it's easy to think about how this might affect erections, because as we talked about, it's all about the blood flow. So anything that's going to restrict blood flow could impact erections. And we'll talk a little bit more later about how medications can also cause or increase the risk for erectile dysfunction. There are 2 main classifications for erectile dysfunction. There's organic erectile dysfunction, which accounts for approximately 80% of the cases, and these are causes related to the vascular, the neurologic, or the hormonal systems. And as we mentioned before, vascular is the most common cause. Then in about 20% of ED, it's considered psychogenic ED, and this would be from causes such as depression, Alzheimer's disease, and anxiety. So more of a psychological component there. So again, it's important to think about and try to target the underlying cause if possible. This is a very busy slide, and it's only provided for your information, but it includes a brief overview of some of the classes of medications that have been shown or believed to cause erectile dysfunction. Again, don't worry about knowing these examples, but it just goes to show the importance of doing a very thorough medication history with the patient because there are so many medications that can cause or worsen erectile dysfunction. Patients may not think of medications that they are taking for their allergies or their hypertension to also be affecting their sexual function, so it's important that you really get a thorough medication history when assessing a patient. Again, like almost every disorder we've talked about, non-pharmacologic measures are a great place to start, and it helps to treat the underlying cause. So things like staying physically active, reducing your BMI if you're overweight, reducing your cholesterol level, and quitting smoking. Again, these are all things that can improve the blood flow. Also on this slide is the vacuum device. While it is more of an intervention than the non-pharmacologic measures, it's still considered a non-pharmacologic measure because it's not a medication or an over-the-counter medication. It generally works well with 60 to 80% reported satisfaction. However, it has some limitations because the onset is slow, it takes about 30 minutes, and it's not very discreet. But for these reasons, it does work well for older patients who are married or in a stable sexual relationship where these factors may not be as important. And again, these devices work by increasing blood flow to the penis. Switching into the pharmacologic options, the first thing to think about relates back to what the vague definition of erectile dysfunction is. Before treatment, it's important for patients and partners to have reasonable expectations of therapy. While some of the medications are very effective, they're not necessarily wonder pills, and the patients may need to adjust their expectations to feel that therapy was successful for meeting that satisfactory intercourse or activity. The most commonly prescribed treatments are the phosphodiesterase 5 inhibitors, also called the PDEIs. This is the class we will cover most in depth, and I will provide some other treatment options just as FYI and for completeness. The PDEIs, or the phosphodiesterase 5 inhibitors, are the first-line agents because they are effective, convenient, and they generally have less side effects than other options. This class of medications has a very unique history. The drug developers were initially trying to use this medication to treat high blood pressure and chest pain, also called angina, but during the drug trials, they found out that it wasn't the greatest for hypertension, but that the patients were reporting increased frequency of erections. So they started to look at it to treat erections, and now that's what it's used for primarily today. Although sildenafil, also known as Viagra, is still sometimes used to treat pulmonary hypertension in patients. So you may see it used daily for pulmonary hypertension. So how do these medications work? They help dilate the blood vessels, which provide that increased blood flow into the penis. Looking at more detail, so when the body is sexually stimulated, it releases nitric oxide and some other byproducts from the nitric oxide, and these act as vasodilators, which dilate the blood vessels so more blood can flow into the penis. The byproducts of this nitric oxide release are typically broken down by the enzyme called phosphodiesterase. So these medications, the phosphodiesterase inhibitors, block that enzyme. So when that enzyme is blocked, it cannot break down the byproducts of that nitric oxide, so the vasodilation stays active for longer, which helps overall to keep the blood flow coming into the penis to affect that balance of inward and outward flow of blood from the penis. You will notice that this mechanism does still rely on the body's natural production of that nitric oxide and byproducts, which is why these medications are not always a magic pill. There are 3 different commercially available agents, and all have relatively similar efficacy, although patients may find that one works better for them than the other. In general, there's a dose-dependent or dose-related effectiveness, meaning that at higher doses, the medication is generally more effective. However, there is a ceiling effect, meaning that at a certain point, a higher dose is not going to be more effective and may just lead to more side effects. It's noted that there's a lower response rate in general for patients with diabetes or patients who have had prostate surgery or removal. This is hypothesized to be related to nerve signaling and functioning. While these medications are effective, about 30 to 40% of patients do not respond. As we've talked about, there are many factors that play into erectile dysfunction, so patients are encouraged to try the medication 5 to 8 different times, so not 5 to 8 different doses at the same time, but 5 to 8 different times, meaning different encounters, before treatment is considered a failure. And again, it's very important to counsel patients that they still need to engage in sexual stimulation for the best response to help facilitate the erection. So even though efficacy is pretty similar, there are some differences between the agents. And again, if you have a non-responder, you could try one of the other agents that might be more effective for that patient. Looking at the pharmacokinetics, vardenafil and sildenafil have a very similar onset of action and length of duration. They work in approximately 30 to 60 minutes, and the duration is about 4 to 5 hours. In comparison, tadalafil or Cialis takes longer to work, so it takes about 2 hours to have that onset, but it has approximately a 36-hour duration due to a longer half-life. So this means that with one tablet, you have the potential to have more spontaneity over several days, as opposed to having to be a little bit more planned with vardenafil and sildenafil. Most of the side effects are mild or moderate and are generally self-limiting, pretty similar across the whole class of medication. Patients often become tolerant to these side effects with continued use, and additionally, patients are often willing to deal with some of these side effects if they're able to continue having sexual activity with their partners. Blurred vision can be one of the more common side effects, and it is most common with sildenafil and least common with tadalafil. However, tadalafil is known for having more muscle aches or pains, and this may be because it stays in the system longer due to that longer half-life and duration of action that we talked about. An important side effect to be aware of and to counsel on is priapism. So this is an erection lasting longer than 4 hours. You often hear this in the end of the commercials when they say, if you have an erection lasting than 4 hours, seek medical attention. This can actually be a very serious concern, and it's important to talk to patients about this. This is also why the medication should not be used in patients with normal erectile dysfunction, because they are at an increased risk for priapism. If the erection lasts for a long time, there's a lack of blood flow in and out of the penis, so there's less fresh oxygenated blood providing oxygen to the cells. So without this fresh oxygen, it can lead to cell and tissue death. Another precaution is that patients need to be healthy enough for sexual activity. So there's a short list of some examples of patients who are contraindicated from using these medications just because they're not considered healthy enough for sexual activity. The most important drug interaction to be aware of is with the class of medications called nitrates. Nitrates are used to treat chest pain that is caused by a lack of blood flow to the heart. When taken in combination, it can cause severe hypotension or a very low blood pressure that can be dangerous because of the similar mechanism of action between the PDEIs and the nitrates. It's important to note that this does not include nitrates that are found in food. We're only talking about the class of medication called nitrates. Some patients only use nitrates on an as-needed basis, so it's possible for someone to have a prescription for both nitrates and a PDEI. Therefore, it's important to counsel the patients that they should wait at least 48 hours after taking Cialis and at least 24 hours after taking Viagra or Levitra to take a nitrate without being under medical supervision. So if a patient were to take, either Viagra or Levitra, and then within the next 24 hours they started having chest pain where they would normally take a nitrate to reduce that chest pain, they would want to seek medical attention. Another common drug interaction is the 3A4 inhibitors. So the phosphodiesterase inhibitor medications are metabolized through the CYP3A4 system in the liver. So the 3A4 inhibitors, again, they're going to inhibit the enzymes that would normally break down the medications. So there's less breakdown of the medication, so there's more active drug in this system. This increase in drug level can lead to side effects and can be dangerous. So if you were to be on any of these inhibitor medications, you would likely need a lower dose of the phosphodiesterase inhibitor to get the same effect, and you should be monitored for side effects. Now we will talk about some of the other agents that are sometimes used in erectile dysfunction, and all these agents are just kind of for your information. Testosterone is focused on correcting the hormonal imbalance. So if you remember back to those 4 systems we talked about, there was the hormonal system. So that's one of the systems that we need to keep in check to help with erectile dysfunction. We only use testosterone to supplement if the patient has a baseline low level. We're only correcting the underlying cause, and we're not doing anything specific for erectile dysfunction, and we're not over supplementing testosterone if the patient does not have a low baseline testosterone level. There are several routes of administration for testosterone, but you do not see oral tablet testosterone. This is because it was metabolized and broken down very quickly, and it was also associated with liver damage. One potential side effect of testosterone supplementation is gynecomastia, and this is an increase in male breast tissue. So, excess testosterone in the body can be converted to estradiol, which is generally considered a more predominantly female hormone. And this increases the levels of estrogen in the male body, which can lead to that gynecomastia. Also, some conditions such as BPH or benign prostatic hyperplasia and prostate cancer can be worsened by testosterone, so it's important to screen the patients for these diseases before starting testosterone therapy. Alprostadil was more prevalent before the phosphodiesterase inhibitors were around. This medication is a prostaglandin and vasodilator, and again, it works by increasing blood flow to the penis. It has a few different brand names. You can see Muse or Caverject. The medication is either injected or inserted locally because if this medication were taken orally, it would cause systemic reactions throughout the body. So the two routes of administration are either injection directly into the penis, and that is the intracavernosal injection, and that has a high efficacy of 70 to 90%, or the insertion of a small suppository, which is the intraurethral administration, and that has a slightly lower efficacy at 43 to 60%. These medications have some requirements because of the somewhat complicated route of administration. So the patients need to be able to safely give themselves an injection through aseptic technique, which means minimizing the risk of infection or contamination with an injection. And they also need to have appropriate manual dexterity and visual acuity to safely administer the medication. And similarly, like the other phosphodiesterase inhibitors, these medications can also cause priapism. This slide includes two examples of unapproved agents that are sometimes used to treat erectile dysfunction. This slide is being included just to emphasize that patients will use medications off-label, such as trazodone, but sometimes the efficacy of these off-label uses is not well documented. Another example is yohimbine, which is an herbal product that again has conflicting evidence of being effective and in one study showed no more efficacy than a placebo. Especially for something like erectile dysfunction, patients may not want to talk to their doctor about treatment, or treatment may be very expensive because it's often not covered by insurance. So patients may resort to trying herbals or other supplements that claim to help with erectile dysfunction. It's important to remember that just because something is an over-the-counter or an herbal or supplement does not mean that it is safe or without side effects or consequences. Additionally, playing off of patients' desire to want cheap fixes or fixes without having to talk to their doctor, you'll see a lot of advertisements online for buying these kinds of medications online across the border. And again, we never support ordering prescription medications online unless it's through an approved kind of mail order online pharmacy. Additionally, there were some concerns of over-the-counter supplements that actually contained chemical compounds that were very similar to the phosphodiesterase inhibitor compounds, which is not legal to sell a prescription medication over the counter, that same ingredient. So this is misbranding of the medication. And as we talked about, there can be many interactions with other medications and with disease states. So it can be very dangerous for these people to be taking kind of these unknown supplements to try to help erectile dysfunction. To wrap up this presentation, let's review the treatment goals. You want to improve the quantity and quality of penile erections suitable for intercourse. You want to avoid adverse drug reactions and drug interactions. And overall, you want to make sure that you're keeping the patient safety at the forefront of your decisions and that your assessment of the patient is very thorough. And in summary, erectile dysfunction is increasingly prevalent and the incidence increases as you age, but it can be related to many other factors. It's important to try and resolve and treat the underlying conditions for full benefit, but the phosphodiesterase 5 inhibitors are the main treatment and are effective for many patients.